With just one word, I bet half of you would immediately stop watching. One word. Why? One word. Periods. We're talking women's periods, menstrual cycles, a health topic, half the world's population. Yet it's a taboo topic to talk about periods. And on a business show, why are we talking about periods? Well, it's National Women's Health Week. And I think that's what this week was designed to talk about. The topics, not the fluff topics for women in health, but the real hard-hitting topics that for some reason are stigmatized or taboo to talk about. Well, not on this show. This is Expert Connections. I'm Julie Holton, and this week, today, we're talking about National Women's Health Week. And that's right, we're going to talk about menstrual cycles and periods. It's just one of many topics we cover in today's episode. Expert Connections starts now. Welcome to Expert Connections. I'm Julie Holton. Our guest today is Dr. Malayev from Metro OBGYN. Dr. Malayev, welcome to the show.
Thank you so much for having me, Julie. It's a great honor. I've been watching it for a while.
Oh, thank you. And I'm so glad to have you here because I want to start with a topic that I think more people need to be talking about. It's one of those taboo topics that people need to talk about more openly. I'm talking about periods. Half the world's population, at least, all healthy women of a certain age range have a period, yet it seems to be something that, especially in a professional environment, is just not talked about. So let's talk about periods. You say that a menstrual cycle is an important indicator of a woman's health. What do you mean?
I definitely have called it like the barometer of your health, because if you are healthy enough, if you have no chronic medical conditions, you're not actively gaining or losing weight because of an illness, your period should be normal. So if something is going on and your period is changing out of its regular pattern that you've been used to for a long time, we've got to look at why is that happening? Is it because you're developing a thyroid illness? Is it because you've got something metabolic going on? Or is there something structural that's happening that's causing your period characteristics to change? All of that involves an open conversation with your gynecologist.
Do you think women wait too long? Do you see women in your practice that maybe are struggling with changes that you wish would come to you sooner?
Yeah, I mean, usually I tell them at every appointment, as long as you're within your normal pattern between 21 and 35 days, less than 7 days of bleeding, just live your life. But if somehow your cycles are coming closer than 21 days, or somehow longer than 35 days, or suddenly you were bleeding 2 to 3 days, it was real light, you needed, a couple panty liners and a tampon, and now you're soaking super pluses for a week, that's a big deal. We got to talk about that. Like, why is this happening to you?
Yeah, absolutely. It seems, I know even women in my circle seem to suffer silently and may not even know that there's a bigger condition or something that needs to be addressed. I don't know why do women do that? Why don't we talk about this more?
I don't know, because it seems like even on my group text this morning with some of my mom friends, we were discussing, like period problems and some of the common ailments that we all suffer from, and we're all educated professional women, yet here we are complaining to each other and not to our doctors.
Yeah, absolutely. I love on Instagram, Metro OBGYN's Instagram, you even profiled your dog, Rosie, and some of her ups and downs with her own cycle, which thankfully, is not the same as a human cycle.
God, could you imagine if you bled for 3 weeks at a time? Like, that would be awful.
No.
But she has gained some emotional maturity with every cycle. And I think she's had like 3 now, and she's real sweet.
And she's lucky to have you.
I don't know about this. My floors are suffering a little bit, but that's okay.
But social media has been a great way to be able to connect with people and have more of these conversations. How are you using social media, or even for yourself personally? Are there accounts that you follow that help you to keep up with information that's kind of need to know for women?
Yeah, so I always follow all the big societies, like the Society for Maternal Fetal Medicine and the American College of Obstetricians and Gynecologists. So I think it's my SMFM and then acog.org or acog underscore, or I have to double check that one, but it's acog.
We'll throw it in the comments. Yeah,
Yeah.
we'll put the links there.
So they're fantastic. They always talk about the new updates and all that stuff. Of course, I always follow the New York Times because they're an excellent, well-researched aggregator of data. In fact, just a couple days ago, the New York Times published that the U.S. Preventative Services Task Force finally aligned their recommendations regarding women's health with all the other major societies like ACOG, the American Cancer Society, et cetera. And they're talking about like, when do you start preventative screening mammograms? And now everyone's aligned at 40, unless you're within a certain population that needs to start earlier. But we can talk about that more.
Let's talk about that then. Different recommendations for different screening ages. And so what do you recommend specifically with mammograms?
So specifically, I say start at 40, go every year, start with the mammogram, ultrasound if you need it, unless you have some risk factors, like there was a first degree relative, meaning a mother or a sister that was diagnosed at younger than 50, in which case you would be starting 10 years before she was diagnosed. So for example, if your mother was 45 at the time that she had breast cancer, you're starting at 35. If your mother was 32, then you got to have a different conversation with your doctor. You might be starting in your 20s.
Okay, good to know.
Now, what if you've got a really strong family history? Maybe your mother never had breast cancer, but all your aunts did and all your cousins on one side of the family. And you find out that you have a genetic mutation that predisposes you to certain cancers like breast cancer, ovarian cancer, et cetera. Like everybody's heard of BRCA because Angelina Jolie kind of publicized that some 10 years ago when she went through her screening and prophylactic surgical issues with that. So if you've got that condition, you're starting at 25, you're alternating your mammograms and your MRIs and your breast exams, and you're seeing a surgeon, you're seeing a geneticist, you're discussing, risk reduction surgery, like potentially a mastectomy or an oophorectomy where you're removing your ovaries. If you're not done with your childbearing, then that's something that you and your doctor are just going to have to watch closely until you are ready to be finished.
Okay, let's talk sexual health. This is another one of those often taboo topics, or at least something that maybe gets glamorized by the media, shows we watch, things like that. But when it comes to sexual health, there may be lesser known conditions or issues that women aren't fully aware of. For instance, STDs, as they were taught to us when we were younger, are now called STIs. What's the reason for the change in this?
I think it's because it's like an infection. It's curable. It shouldn't be a stigma. Like you don't have it forever. Okay, so you had chlamydia, you took medicine. It's not a disease. It's an infection. You're done with it. It's like pneumonia. Some of the other ones are more like chronic conditions, but at the same time, they're easily managed. There are some other things that we talk about with sexual health and, pelvic inflammatory disease and the importance of yearly screening. So going back to all these guidelines, most guidelines recommend that adolescents between 13 and 15, even if they're not sexually active, come and talk to the gynecologist. We're not doing an exam. We're just having a conversation. And this is something that I say on social media. This is something I say to the moms of teenagers, like, hey, you should bring your daughter in. We'll go over these things in a totally non-judgmental manner. And then when she's ready or when she needs these services, she'll be able to reach out to another trusted adult. Like if she's a little scared to say something to you, she can always reach out to me. I can just be like, okay, hey, your period's not normal. Or, hey, I know that you just started having intercourse with your partner, but for some reason now you're complaining that it's painful. Like it shouldn't be painful. Like let's explore that further. And then it's another trusted adult.
Well, and that's one of the things I was going to ask you. I was just talking with a girlfriend yesterday whose 9-year-old has already started her period. So at what age do you recommend? Is it based on family history and maybe when, a woman started her period or her mom or sisters or whatever, or that maybe young girls come in sooner? But what age range should we be
I've never seen
about?
I've not seen a 9-year-old in my practice yet, but I know it's possible. My best friend, I think, was also like 9 or 10 when she started. But, some people are heavier. Some people have better nutrition than they did even 30 years ago or even 100 years ago. Because, 100 years ago, maybe people were starting their periods closer to 15 or 16 because the nutritional support just wasn't there. And now we have all the resources to be in better health, to have better nutrition, better growth, better support, like way less stress on our bodies. And we might be starting earlier.
I really appreciate one of the things that you touched on that I'm going to repeat because I think it bears repeating is giving children another trusted adult to come to. I mean, who can you trust more than, especially with your health, than a doctor? I know the moms in my mom's group, we talk about this all the time. My sister and I talk about this, making sure that our kids have other adults that are available to them to answer questions, because also kids don't always, listen to mom or dad or think mom or dad know everything, but to have that other trusted adult is so important. Okay, Dr. Malayev, another topic often taboo that you even mentioned, I think an important one for women. We're talking about sexual pain, libido changes, another topic or series of topics that women also maybe aren't talking about enough. Can you share any insights or advice on sexual wellness and when we need to be having these conversations?
I think we need to evaluate it every time that we see each other. I always ask, like, what's new in your life? Like, are you dating anybody new? Are there any problems? Is anything painful? If you say, oh yeah, once it hurt, in the last year, I'm not going to think or worry about that. But if you're telling me every time you're having intercourse on these certain days of the month, within your cycle, it's starting to be painful, or you're noticing that in certain positions or with certain angles, things are more uncomfortable, I'm going to be thinking about endometriosis. And I'm going to mention that to you. And then we're going to talk through your sexual health a little bit more. We're going to go through a very detailed history, like what positions, what angles, what kind of equipment are you working with? Things like that. Because what if it's just that your partner is unusually well endowed and this never happened before in the past? Well, then that's a partner problem. But if it's like, oh, it doesn't matter who the partner is, this is always happening. It doesn't matter what the activity is. This is always uncomfortable from about week 2 of the cycle until the period starts. Then we've really got to think about endo. And then when we talk to women about it, they're always like shocked to hear like this could be happening to them. Or some of them say, well, actually everyone in my family has this, and like no one could get pregnant and this was going on. And then you tell them this shocking statistic. It takes about 7 years for a woman to get that diagnosis. And at first I thought that was crazy, because like, how could it take 7 years to make that diagnosis? Like, it's so obvious that the patient will tell you everything that you need to know to make that diagnosis. But the hard part is, the only way, truly the gold standard to diagnose it, is to do surgery, and not everybody is ready for that. I mean, you can suspect it from their history. Sometimes you can see a large collection of endometriosis, something called an endometrioma, on ultrasound. Sometimes on more advanced imaging, you can see something called adenomyosis, which is a type of endo within the muscle of the uterus. But typically that woman's not coming in with painful sex. She's coming in with painful periods or very heavy periods. So anyway, you can suspect these things, and then you can say, like, we could go to the OR. There are these newer medications. We can try these things and see if you feel better. And surgery is both diagnostic and therapeutic. And I think back, even just on the last 7 years of practice, there are some people, it's taken me 4 or 5 years to get them to the OR. And so I think, okay, well, I'm a little under the average for the 7-year mark, but that's still a long time for somebody to suffer. Or like they're coming in and they're saying, sometimes it's better and sometimes it's not. Or like, it's not a super clear story. Like no one's coming in and saying, I've got implants, in my pelvis and it hurts.
Well, and the important thing here is to start having the conversation for patients
Right.
to talk with you openly about what they're experiencing so that you can help them get better outcomes sooner.
Right. And that's always my goal, is to make sure that like you are having fun. And then, as these women are getting a little bit older and they're like, oh yeah, my husband and I, we used to have this thriving sex life, but now that we have whatever it may be, whether it's the mental load of motherhood, whether it's some other, anxiety or anxiety medication lowering their libido, or the fact that their hormones just aren't the same as when they were 20. Or that they're on birth control or something else is going on, then we've got to look at the libido issues. And we have to, first we start with, is the relationship good? Do you not want to have intimacy because you and your partner is it a partner problem? And then when it's not a partner problem, then you say, okay, is it a physical problem? And then they're like, well, yeah, it hurts. It feels like knives and razors when we have sex. It's like, well, how are you going to want to have sex if it's hurting you every single time? So let's explore why that is. Is it because you have, atrophy from a lack of estrogen, from being, perimenopausal, or from being on a birth control that's too suppressive for you? Is it because you have a skin condition called lichen sclerosis, which is a dermatologic issue that causes the skin to become very thin and not stretch, and it tears with contact? So again, how are you going to want to do anything that's going to cause you that much discomfort? And then once you start having an open conversation and laying out a treatment plan, whether it's, topical steroids, changing some other medications, adding a medicine or a vitamin for libido, there are other choices that you can make to improve your outcomes.
I want to talk now about hormonal changes. Throughout a woman's life, they can present all sorts of challenges, to put it nicely. Are there treatments or therapies, whether it's for hormonal imbalances or conditions like PCOS? What are you finding that's helpful for women in your practice?
So everyone comes to me and they're like, my hormones are wacky. Can you check them? And it's like, well, I can, but they're going to be normal because they're not wacky. This is just kind of how they fluctuate in your cycle. Like, I'll check them. I'll prove to you that your thyroid is okay, that, your female hormones are in the normal, ovulatory range, that there's no sign of PCOS. And then we talk about, like, what are your symptoms that you are experiencing? Is it because you are suddenly very moody? Could you have something called premenstrual dysphoric disorder, which is a type of severe PMS, which is notoriously difficult to treat? That's a mood disorder. That's not a period disorder, but you manage it like a period disorder with some birth control pills. Is it because you are perimenopausal and you don't have enough estrogen and now you're not sleeping well, so you're constantly irritated? So is it because you've got to add something to help you sleep or help you not have hot flashes so that you are overall a less sleep deprived and cranky person? Again, there's nothing wrong with your hormones. It's just part of your normal fluctuation, but we've got to know how to manage that to make it a more comfortable thing. Like, I'm having that. I can't sleep. I haven't slept well in 4 years. So, like, I have to take something to help kind of stabilize the sweating so that I can sleep better at night, so that I'm not such a grumpy bear in the mornings. Because, if you've gotten 2 to 3 hours of good sleep and 4 hours of tossing and turning sleep, you're not going to be a very nice person in the morning. Then your family won't like you, and then you'll get all the partner problems and everything else.
Well, it's interesting, though, to hear you talking about this, too, because I wouldn't necessarily think that my OBGYN wants to hear about whether I'm sleeping or not at night.
I do ask about it because if you're having hot flashes, you're not sleeping. If you're waking up in a puddle of sweat, and I tell this to all the breastfeeding moms because no one told this to me, breastfeeding is like menopause. It's like a fun little sneak preview. And now that I've experienced it, I'm a lot more empathetic to these, perimenopausal and menopausal women that are coming into my office. Like, oh, you soaked your sheets at night. You had to change them 3 times during the night. That's very disruptive to your sleep. I know about this because I went through this. It sucks. Like, these are the options that we have. Like, let's try them. Let me know how you feel in 6 weeks.
Well, and menopause itself is a topic for an entire another episode. In fact, I have a friend doing a 6-part series, a podcast series just on menopause related to the workplace and changes that she wants to see happen with how, that's again, another segment for another time. I think I always say this, if men, and I say this with love because I love men. I have a lot of men in my life who are amazing, wonderful men. But if they actually experienced the similar health experiences that we have and the fluctuations throughout the month,
they would be really grumpy bears.
Things would be so different with how work hours are run. And in fact, I actually, I need to look more into this, but I don't know if you've heard of this. I was hearing that there's a book that talks about scheduling your month as a woman, scheduling your month and your meetings. And when you have your most important work, the deals that need to be done, in a business, contract deals, whatever, scheduling that around your period. So
you should definitely do that. I am the most assertive the week leading up to my period. I'm like, we are getting this done.
Wait, what? Adjusting your work schedule around your monthly periods. That's coming up tomorrow in part 2 with Dr. Malayev. Plus, is COVID impacting male fertility? We dive into it tomorrow on Expert Connections. Join us for part 2 and make sure to click down below and subscribe.